Good afternoon and welcome to today's IAC webinar, Quality of Life Measures in Venous Disease. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar, please note the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest presenter, Dr. Arjun Jayaraj. Dr. Jayaraj is a vascular surgeon at the Rain Center for Venous and Lymphatic Diseases in Jackson, Mississippi. He serves on the IAC Vein Board of Directors as a representative of the Society for Vascular Surgery. A true expert in the field, and we are happy to have him with us today. And with that said, I will now turn this webinar over to today's speaker, Dr. Arjun Jayaraj. Doctor?
Thank you, Kelly. At the outset, I would like to thank the IAC for the opportunity to present today. I have no financial disclosures relevant to this talk. Now, health has been defined in a variety of ways. This is the definition that is enshrined in the Constitution of the World Health Organization. It defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Quality of life, again, has been defined in multiple ways. This is the definition from Nanette Wenger and her group, which defines quality of life as a wide range of capabilities, limitations, symptoms, and psychosocial characteristics that describe an individual's ability to function and derive satisfaction from a variety of roles. Now, what is the utility of a quality of life measure? Well, it helps us evaluate how our patients are impacted by disease. It helps assess the impact of intervention on reducing this impact. And it also offers a reliable and precise measurement of success and the cost of treatment. Quality of life measures can be broken down into generic measures and disease-specific measures. Now, before I go into the details of these, I would like to say a few words about creating a quality of life measure. The first step is to actually develop a questionnaire, and this involves devising and scoring questions. Oftentimes, these questions go into several hundreds to a couple of thousand, and they are whittled down based on their ability to define the particular measure. And then these questions are pre-tested on a small group of questions, and test questions are subsequently determined, which are then tested on a larger sample of patients. Internal consistency is then assessed, and then the questionnaire is subsequently finalized. Next step after finalizing the questionnaire is to actually validate it in a large sample of patients or in multiple samples of patients through multiple studies. And then one needs to compare the results with the general populations to make sure that it's actually capturing the relevant disease or not. A few terms need to be defined with regards to quality of life. measures. One is validity, which is the extent to which a questionnaire measures what it is intended to measure. Reliability, which is the extent to which measurements on the same individual are similar under different conditions. And then you have responsiveness, which is the extent to which an instrument is able to detect clinically important changes over time. And then acceptability, which is the ease with which individuals can complete a particular questionnaire. Coming back to generic measures of quality of life, these are the most commonly used ones. You have the short form 36, and then you have the short form 20 and 12, the Nottingham Health Profile, and the European Quality of Life Instrument, the VEINES-QOL. Now, besides these, there are several other instruments which serve as generic measures. You have the McGill Short Form Pain Questionnaire, the French Activities Index, Symptom Rating Test, and so on. As far as venous disease-specific quality of life measures go, we have the Venous Insufficiency Epidemiological and Economic Study on Quality of Life Symptoms, the VEINES Quality of Life Symptom. We have the Chronic Venous Insufficiency Questionnaire, the CIVIQ, and the Aberdeen Varicose Vein Questionnaire, the AVVQ. And then there are others as well that fall into this group, the Freiberger Questionnaire, the Health Questionnaire for Venous Disease. And then you have questionnaires that are focused on individual venous problems, deep vein thrombosis, leg ulcers, and so on. I would also like to cover some aspects of venous disease specific clinical measures as part of this talk, and this will include the CEAP classification, the Venous Clinical Severity Score, the Villalta-Prandoni scale, and the Varicose Vein Symptom Questionnaire. Now, coming to the generic measures, the short form 36, it came out of the medical outcome study, which was a multi-year, multi-site study to explain variations in patient outcomes that was carried out by the RAND Corporation. And so the original health survey is termed as a RAND 36-item health survey. There's actually also a commercially available version, which is the medical outcome study SF36. The questionnaire used in both these surveys are identical. The only difference is the way the scoring is carried out. Both of them have 36 items spread over 8 scales and 2 dimensions. The scoring is from 1 to 6, and they're all recoded from a 0 to 100 level, and these items are actually averaged to create scales. Now, the modified versions, the SF20 and SF12, they're both adapted from the SF36. One of the goals has been to reduce the respondent burden time, and they both achieve minimum standards of precision for purposes of group comparisons. The SF12 captures about 90% of the reach of the SF36 instrument, and virtually no difference between the SF36 and SF12 in scoring health status has been found. And this is the SF36 instrument, and you'll notice that there are 2 dimensions, physical health and mental health, and 8 different scales into which the 36 questions are grouped. And this is the SF20 instrument that has 20 questions. Now, the advantages of the short form questionnaires, they are clinically and psychometrically consistent. Evaluation across multiple scales and dimensions can be performed, been thoroughly validated, and it's applicable to a wide range of diseases. On the other hand, they generally take more than 5 minutes to complete, especially the SF36. Now, SF12 leaves about 10% of data uncaptured. How relevant this uncaptured data is will depend on the type of question that is being tried to be answered in the study. And they are generic, and so they really can't be applied to specific disease. For example, they're unable to capture the difference between patients with and without post-thrombotic syndrome. The Nottingham Health Profile, it came out of work done at the Department of Community Health at the University of Nottingham. It's a short assessment of emotional, social, and physical health problems. It has 2 parts, 38 questions over 6 sub-areas, and there is a 7 life area questions, which is actually an optional part. And the score is actually generated by subtracting the sum of the weighted scores in each sub-area from 100, and then converting and then dividing it by 100. So you end up with a score from 0 to 1, and 0 indicates poor health and 1 good health. And this is the Nottingham Health Profile, and you'll notice they're all yes or no questions, And each question has a particular section that it subscribes to, and then there's a weighted score for each of these questions. And part 2 is the 7 set questions that is optional. The advantages, it's simple wording and easy to understand. This really does take about 5 minutes to complete. It has been thoroughly validated and has good reliability. As far as the limitations go, it has difficulty in picking up milder forms of a disease, and so it affects its applicability in the general population. It's also hard for the Nottingham Health Profile to detect change over time. It assesses negative aspects of health rather than positive. So in a sense, it's sort of contrary to the concept of quality of life, which is sort of well-being. Now, the VEINES-QOL, it was developed by the VEINES-QOL group as a non-disease specific instrument to describe and value health-related specific quality of life. The original instrument was the EQ5D3L that came out in 1990. 5D refers to 5 dimensions and 3L refers to 3 levels. And the dimensions are mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. And the 3 levels are no problem, some, and extreme problems. Now, this instrument also has a visual analog scale that records the patient's self-related health. The more recent version is the EQ5D5L, where the number of levels was expanded to 5, and so it goes from no, slight, moderate, severe to extreme problems. It also has the VAS instrument. A pediatric version has been introduced at the same time, and more recently they're working on a health and well-being instrument. Scoring is actually done using country-dependent weighted value sets. And this is the VEINES-QOL 5D5L. You'll notice there are 5 dimensions, and there are 5 levels for each dimension. And on the right-hand side is the scale where 100 is the best health one can imagine, 0 is the worst health, and the patient is asked to score their health. Advantages of the VEINES-QOL, it's short and simple. It's been validated in multiple languages, and it can be used to compute quality-adjusted life years. As far as the limitations go, there is an impact from a socio-cultural context. So you require a country-specific algorithm. And so if you're doing studies across multiple countries, how do you reconcile the differences? That could be an issue. And it's also influenced by comorbidities and aging over the long term. So long-term studies that use the VEINES-QOL might find it hard to discern effects of treatment and disease progression. Now, as far as the venous disease-specific quality of life measures go, the VEINES instrument, it's a 26-item instrument. 21 items cover symptoms, limitations in daily activities, time of greatest intensity and change over the past year. And there are 5 items that cover the psychological impact. And the rating is done from a 2 to a 6-point response scale. 2 scores are computed. One is the VEINES Quality of Life score, which provides an estimate of the overall impact of venous disease on the patient's quality of life. And then you have the VEINES Symptom score, which has 10 items and measures symptom severity. So this is the instrument. Now, questions 1 and 7 are actually used to measure the VEINES symptom score, and all 8 questions except 2 is used to score the quality of life score. As far as advantages goes, it's an easy to use instrument. Again, applicability across multiple languages exist. Reliability and validity have been thoroughly evaluated. It covers a wide spectrum of venous disease. As far as limitations go, it excludes anatomical and physiological parameters, and sometimes in venous disease, these actually guide treatment choice. Responsiveness to different treatments, like different interventions on the same patient population, might be difficult to discern using the VEINES instrument. And it also has some limitations with regards to measuring clinical differences between populations when you use multiple populations as part of the study. Now, the CIVIQ questionnaire, there is a CIVIQ 20, which is a 20-item questionnaire across 4 dimensions: pain, physical, psychological, and social. And there is a 14-item questionnaire across 3 dimensions: there was some factorial instability in the social dimension between populations. And so they got rid of that in order to give the questionnaire more stability. And so that's the basis for this CIVIQ 14. Scores are actually generated for each dimension, and there's also a global index score, and it's country specific. And this one is for the US. So a total of 20 questions, and they're all scored from 1 through 5. Now, advantages of the CIVIQ instrument: it's got good validity and responsiveness. It's a reliable scale for both discriminative and evaluative results, and it has been linguistically validated. The limitations: all the studies that were done to actually validate the instrument were done for CEAP clinical class 0 to 4 patients. So it really doesn't cover patients with ulcers, either active or healed. So that's one of the shortcomings of the instrument. The multiple studies who have C5, C6 patients have used the CIVIQ instrument, but it's just not been validated for those patients. The other limitation is the factorial instability that I pointed out, as a result of which the C14 is probably the better instrument when you're trying to assess multiple populations. The Aberdeen Varicose Vein Questionnaire, developed in '93 to assess perceived health of patients with varicose veins. It's got a total of 13 items with 12 questions and 1 drawing task. It addresses the physical, social, and cosmetic aspects. The responses are rescaled to yield scores from 0 to 100, and 0 is the best quality of life and 100 is the worst. Now you'll notice that depending on the instrument, 0 and 100 could mean very different things. So they're not all uniform, and so that's important to keep in mind when evaluating studies that have used different instruments. Now, these are the set of 13 questions that's used in the instrument. The original instrument had 15 questions. They did away with 2 questions, one which pertained to at what point in the day was the pain the worst, and second related to use of diuretics for symptom relief. And so the final instrument has 13 questions, the first one of which is the diagrammatic response. Advantages: it's short and easy to complete like some of the other instruments. It's sensitive to disease burden as well as changes over time. It is able to discriminate patients with mild disease, and there's a strong correlation with the EQ5D as well as the SF36 instruments. Limitations: it's a varicose vein questionnaire, so it's unsuitable for patients with chronic venous insufficiency, including post-thrombotic syndrome. There is an overlap of symptoms with other venous conditions. Only 4 out of 13 actually address non-physical aspects, so you could make the case that perhaps it's more of a severity score than a quality of life score. And then one can always question the utility of drawing out the varicose veins. Many of our patients are unfortunately unable to do so. Now, as far as the venous disease specific clinic measures, the CEAP classification, originally developed in '93, updated in '96, was revised in 2004, and the last update was carried out in 2020. The clinical, etiology, anatomy, and pathophysiological aspects of venous disease are covered in the classification. And these are the changes that have been made in the latest iteration of the classification. C4C to define Coronaflebectactica has been added. R has been added for recurrent varicose veins and venous ulcers. The etiology, the secondary etiology, has been expanded to include both intravenous and extravenous, and replacement of numeric descriptions of the venous anatomic segments by their common abbreviations has been carried out. And so this is the C class, and you'll notice that there is 2 and 6R, and C4C has been added. This is the etiology part, ESI for intravenous and ESE for extravenous. And the anatomy part has sort of been revamped to include abbreviations of the veins. And this, I think, is very useful. It's easier to use like CIV and EIV versus say 7 or 9. You know, those numbers, it's hard to remember. And this is the pathophysiological aspect: reflux obstruction, reflux and obstruction, or no pathophysiology identified. Advantages, the basic version is simple, it's easy to use. The intra-observer reproducibility is around 85%, pretty good. The 2020 version incorporates items missing from previous versions, and it has good correlation with generic as well as disease-specific quality of life and venous reflux. On the other hand, it does not include pain or claudication, so it's got low content validity in that regard. Outcomes, a longitudinal follow-up is not possible because it's not really a severity score, although multiple studies have used the CEAP classification as a severity score. It's not really set up for that. The inter-observer reproducibility is pretty low, again, 47%. Now, the venous clinical severity score is actually a part of a three-score group that goes by the term of venous severity score. The venous clinical severity score grades the clinical element. The venous segmental disease score covers the reflux obstruction, it grades that. The venous disability score grades the level of work-based disability. The VCSS combines patient-reported and physician-identified items. It's a 30-point score based on 10 items, and 0 to 3 points for the use of compression stockings is included in that. The score was revised in 2010 to improve applicability. And this is the VCSS, and you notice there are 10 variables on the left-hand side, and they are graded from 0 all the way to 3 for none, mild, moderate, and severe form of the variable. Advantages, it complements CEAP. It has good correlation with quality of life measures. It combines patient-reported and physician-determined items, and it is able to measure outcomes, clinical response over time. Now, as far as limitations go, it does not include a myriad of symptoms that a lot of our venous patients experience, including heaviness, tiredness, tightness, cramping, and claudication, and so on. It is weighted towards the latest stages of the CEAP classification. 9 points are devoted to the venous ulcer aspect. There is lack of precision in assessing skin changes, dermatitis versus hypodermic inflammation. And then one can always raise the question of what utility does inclusion of compression stockings serve in the score. The Villalta-Prandoni scale, originally published as an abstract in '94, includes 5 symptoms and 6 signs. Each item is rated on a 4-point scale, 0 to 3. If you have a score of 5 or more, or an ulcer present, then the patient is deemed to have post-thrombotic syndrome. And this instrument was recommended by the International Society of Thrombosis and Hemostasis for use in PTS research. And this is the instrument. You have 5 symptoms, 6 signs, and they're graded from 0 to 3, none through the severe form of the variable. The advantages, it combines symptoms and signs. It does this in a slightly better way than the VCSS instrument does. The grading actually enables assessment of severity and allows for long-term follow-up. There's excellent inter-observer reliability, and it has good correlation with the quality of life measures. However, the symptoms and signs are not all specific for venous disease. It has not been validated for non-PTS conditions. Like the VCSS, it does not evaluate claudication, and the instrument requires prior training. The Varicose Vein Symptom Questionnaire, it arose from the need to develop a patient-reported outcome for varicose veins. It uses 5 items: heaviness, achiness, swelling, throbbing, itching. Each item is rated on a 6-point scale, 0 to 5. Sum of daily scores for 5 items is averaged over 7 days, and you get an overall score somewhere between 0 and 25. Higher the score, greater the symptom duration. Now, the validation study for this instrument was published in an abstract in JVIR about 7 years ago, and it has been used in VANISH 1 and 2 trials. So these are the 5 symptoms: heaviness, achiness, swelling, throbbing, and itching, sort of go by the acronym HASTI, H-A-S-T-I. And again, the grading is from none of the time to all the time, 0 to 5. Advantages, as you have seen, it's simple and easy to administer, very easy actually. It focuses on varicose veins exclusively. It's got good correlation with the veins quality of life measure. As far as the limitations go, it needs further validation. Some of the symptoms are not specific for varicose veins alone. The assessment of reliability and responsiveness also needs to be evaluated. It does have poor correlation with the venous clinical severity score, as well as duplex response. Now, when you put all this together and group them based on acceptability, reliability, validity, and responsiveness, this is sort of how they fall. The first four are generic quality of life measures. The next four are venous disease-specific quality of life measures. The last four are clinical measures of venous disease. Disease types and scores used. So these are just examples. Chronic venous insufficiency, one could use the CEAP and the VCSS instrument. Quality of life, if you have the ability to use both a generic and a venous disease specific quality of life, great. If you could use only one quality of life instrument, it might be better to use a venous disease specific quality of life instrument. The same goes for post-traumatic syndrome. Here you can use the Villalta-Prandoni instrument as well. And quality of life instruments, either venous disease specific, generic quality of life instruments, or both. But I think it is important to use both a clinical instrument as well as a quality of life instrument, because venous disease, unlike arterial disease, is primarily the treatment is focused on improving patients' quality of life. Unlike arterial disease, where the treatment you're trying to do limb salvage, you're trying to save the person's life. So I think quality of life measures, instruments are going to get more and more important as time goes by, as payers see the value in these quality of life measures. As far as varicose veins go, CEAP and the VCSS, and then you can use the Aberdeen Varicose Vein Questionnaire with regards to quality of life. So future direction, improvement of current measures is certainly required and would be a lot helpful. Integration of clinical and quality of life measures to provide a unified score would also be very helpful, especially with regards to studies. It's again very hard to do, and it would also help to have a clinical metric, not quality of life, but a clinical metric for acute deep vein thrombosis. Thank you.
Okay, thank you very much. At this time, we begin the Q&A session. From IAC Vein Center, I'd like to introduce Laura Humphreys, our Director of Accreditation, assisting with the Q&A session today. Laura, would you like to start us off?
Sure, Kelly, thank you. And thank you, Dr. Jayaraj, for a wonderful presentation today. We do have some questions here. The first one is, how do quality of life questionnaires measure the cost of treatment, or do they measure the cost of treatment?
Yes, that's a great question. Not all of them have actually been utilized for that purpose. The EuroQOL is one such instrument that has been, and it all comes down to quality, the quality score, the quality adjusted life years. By giving a patient X treatment, how many additional years of quality life or fraction of additional years of quality life are you giving that patient? And through that, how much are you saving, or versus how much you're spending for that treatment? So you can actually convert the quality of life measures into a metric that can assess the cost for a particular treatment versus not offering the treatment. And this is done actually, particularly in Europe and the UK. Quality of life measures are being used for this purpose. Less so here in the US.
Thank you. So there's a lot of questions about all the quality of life forms. There's a question, what do you use? What do you prefer? What is the best way to choose one for your practice? Should you use more than one? Like how do facilities figure out what they should do and what they should use?
Yeah, that's a great question. And I think it all depends on what the scope of practice of a particular facility is going to be. So if your scope of practice is primarily varicose veins, superficial venous disease, then perhaps, utilizing from a quality of life questionnaire standpoint, it might be best to use something like the Aberdeen Varicose Vein Questionnaire. And once the varicose vein symptom questionnaire gets a little bit more validated, one can use that as a clinic metric. Now, I think, so that would be like the quality of life clinic metric. I think it also helps to have some kind of a basic score like the CEAP score as well. Now, if your spectrum is the entire range of venous disease, all the way from superficial to deep venous disease, then you need metrics that are able to capture that. So in our practice, we certainly use CEAP. We use the VCSS instrument as well. And then we use the CIVIQ questionnaire because that sort of covers, both varicose veins as well as deep venous disease, although it has not been validated for the C5, C6 population. So again, there's a lot of work that needs to be done in terms of administering each of these questionnaires. Both from a patient standpoint to fill these questionnaires and from a practice standpoint to gather all these questionnaires, enter all the data into a database that allows for comparison and so on. So I think whatever instruments you choose has to be tailored to your practice and how practical it is going to be. There is no point having a questionnaire and not being able to use it, or you use it for some time and then stop using it because it's just too cumbersome.
Great, thank you. I also have a couple of questions here. How do we go about obtaining these questionnaires in our practice? Many are copyrighted or not easily accessible. Can you buy them for clinical use in your practice?
Well, yes, not all of them are copyrighted. Let me rephrase that. Not all of them actually require an upfront expense to actually get the questionnaire, but there are expenses associated with actually like being administering them and having a database to actually store all the information. Like the RAND 36 questionnaire, the SF36, the RAND version is actually available free from their website. Now, the VEINES-QOL has got a website that you can access it from. It does require a payment. The Aberdeen Varicose Vein Questionnaire is easily accessible. Now, while the questionnaires might be easy to get, it is more the trying to scale the responses to the questionnaires and coming up with the scores that actually take up time, effort, and money. There are specific programs that actually do the scoring, and that might be something that requires an investment. The actual questionnaire itself might not require investment. I think it again boils down to what instrument works best for your practice. And Laura, if you want, we can perhaps put some links on the IAC website that folks can go to access some of these quality of life instruments.
That would be great. Yes, that would be perfect. We can certainly do that. Let's see. Okay. Here's a question. So the questionnaires, are they filled out by the patient or are they filled out by the patient and the physician?
So the quality of life questionnaires are all filled out by the patient. It's the quality of life of the patient. And so they fill it out, and there are different ways to do it. We've done the paper version, we've done the electronic format for the CIVIQ, and what we found is that a lot of patients have difficulty in filling out the electronic form of the CIVIQ instrument, and so we've had to go back to the paper version. So it's all done by the patient. Which modality you use to have the patients fill it out depends on your patient population. Now the clinical measure, the metrics of clinical diagnosis like the VCSS, the CEAP, as well as the symptom questionnaire, they're all administered by the physicians. They actually talk to the patient and do the assessment. But the quality of life is all filled by the patient, or at least that's what it's supposed to be.
So, and when you're giving these forms to the patients to fill out, do you give them to every single patient, or are you just, choosing random patients to send them to, or does everybody have to fill that out or should fill that out?
No, one needs to have a protocol about how they're going to do it. So in our practice, we administer it to give it to every patient. There is going to be a certain percentage of non-respondents or incomplete forms and so on. So all of the patients, when they come for their first clinic visit and subsequent clinic visit, all get handed the quality of life questionnaire, and they fill it at each visit, and that all those the questionnaires are actually manually entered into a database that we can subsequently analyze. So that is sort of how we do it. You can't really cherry pick. Then when you go back to evaluate your results, you really don't know whether your patients have improved as a result of your intervention or not. So I think you need to administrate to every patient, and then you'll obviously have to exclude those who don't fill the form and who are not able to complete the entire form.
So those patient questionnaires, they're not just given at the first consultation. They're given out every time the patient comes in, or before or after treatment, or multiple times.
Yes, that's what we do in our practice, because the whole point of using quality of life is how they have improved pre and post, and does that improvement sustain over time? And the only way you can capture that change is to administer the instrument at each follow-up visit. We since a lot of our patients actually get ultrasound scans, we've incorporated the administration of the questionnaire as part of the ultrasound scan. So before they get a scan, they fill the questionnaire out. The questionnaire is collected by the ultrasound tech. It's kept in a tray, and then we collect the tray every so many days, and that information is actually entered into a data set. So you need to have some kind of system to administer, to capture the data, and make sure you're doing it on a regular basis.
Okay. I have a question about patient participation. It says, it seems like everyone is sending surveys lately. How do we motivate our patients to participate? Do you have any experience with that?
Well, we don't have a lot of experience with sending people questionnaires and them completing it and sending it back. The data that we capture is typically done when they come to the clinic or the vascular lab, and so they're physically there, and so it is much easier to get them to fill out the form. And if they have any questions, the vascular lab tech is able to explain it to them. And so the sort of the ability to capture data is significantly increased. I personally don't have much experience with sending out questionnaires, so I really don't know what one could do to increase the yield of that. Would it help to telephone them from time to time to remind them? It might, but they might also get irritated and not respond at all. So I don't know.
This is a long question, so if you need me to repeat it, let me know. My understanding of the Venous quality of life is that the scoring requires a closed data set, so it cannot be used for a longitudinal study like a registry, and scores from different studies using the same instrument are not comparable. Is that correct?
Well, that's not Well, as far as so if you're doing, for example, if you're actually evaluating post-thrombotic syndrome in, say, two studies, in different parts of the countries, and you've actually administered the Villalta-Prandoni scale on both of them, and you administered them multiple times over time. Could you theoretically pool the data from both those studies and come up with a much larger sample size? You could, because the disease that you're actually evaluating is the same. The instrument that you're actually evaluating is the same. Now, the thing you have to keep in mind is there a significant difference between the two populations that you're trying to combine? Now, if there is, then it might change. For example, if you were trying to pool a study conducted in the US with a study, say, conducted in China, now, there is a significant difference, sociocultural difference. So you might not really be able to combine those two studies. But as long as there is no significant differences in the populations, then for most of these quality of life measures, you should be able to combine them. Not all of them have been validated in multiple populations and have surmounted the difference in the variation in populations, but some of these metrics have.
Okay, I have a question. Do you know of any quality of life questionnaires, maybe not just venous disease ones, that take diet and nutrition into account?
I don't. So the question would be, what are you trying to capture through the diet and nutrition aspects? Are you trying to see if with whatever intervention you performed, it has improved the dietary and nutritional status of the patient? Or are you trying, you have to frame the question as to what you're trying to capture by using nutrition and dietary data. I'm not. They typically don't fall under the purvey of quality of life. Certainly not for venous disease. Now, could it be that patients are depressed and so it affects their appetite and that impacts their diet and nutrition? It's possible, and there are several instruments. This is only a short glimpse of quality of life instruments used in venous disease. There are many other instruments that are used for a variety of conditions, and if there are conditions which impact diet and nutrition, there will be instruments that actually look at that, but not so much for venous disease.
Thank you. And we have a question here about the QI tool, and I'm going to give you just a little breather. I'm going to ask it, and I'm going to go ahead and answer it from this one particular facility. She's asking, what is the time frame post-procedure for the questionnaire to be done? For QI review, we review cases each month. And the IAC QI tool, our outcome scores are low because the initiation of these questions being filled out is 3, 6, and 12 months post-procedure. When I enter the QI times, it has not been 3 months. So basically, the question is, in the QI tool, we added some new questions that include quality of life scores, as well as quality of life scores pre-procedure, and then at 3 specific intervals after the procedure. And this is what's being referred to here. And what I'll tell you is, right now, the standards do not require the quality of life measures. So even if you don't put a value there, you wouldn't be scored negatively in your QI assessment. This is also applicable to the CEAP and the VCSS scores. If you bring the patient back, yes, we do expect you to have those scores and have them there. If the patient doesn't return and doesn't return for 3 different intervals, that's also acceptable. So it should not affect your overall score of your QI results. I will kind of plug there, we did put those in there to kind of get everybody thinking about it. So if you're not doing any quality of life scoring now, it's something you might want to start thinking about. Okay, so let's see. Can a facility create their own quality of life questionnaire?
Oh, it's creating a quality of life questionnaire is very, very hard work. I went through the multiple steps that are actually required to create a questionnaire, to validate it, compare it with the general population, and so on. Theoretically, can it be done? It can, but it's very hard, and it involves a lot of time and effort from multiple people. So, and the validation part of it is very hard, and so you will require to you will have to conduct large size studies to validate the instrument. So it's you will need help from others beyond your own practice typically.
Great, thank you. So here's a question. What is the difference between joining a quality of life program versus our registry that we participate in, AVLS?
Well, so I think using a quality of life instrument that's validated and that's responsive and reliable is I think is one thing. You can use it irrespective of whether you are part of another registry or not. I'm not exactly sure what the AVLS program has and what are the components to that. Each of these, whether you use the CIVIQ or whether you use the VEINES quality of life or the varicose vein symptom questionnaire, they all have a particular set of questions that either the patient needs to fill out or the physician needs to fill out. I think that part requires to be done irrespective of whether you're part of a registry or not. Now, if you're getting all these scores and you're sending these scores to AVLS or VQI, then that's something different. But being part of a registry and answering a few questions related to quality of life for some patients doesn't necessarily mean utilization of a quality of life instrument.
Okay, thank you. The question here, the CEAP classification seems very rigorous. Can we just use the CEAP part?
Yes, and most practices, I shouldn't say most, a lot of practices actually just use the clinical component of this of the CEAP, and so that's certainly, I think. But remember one thing: CEAP is a static score. It's you typically get it when the patient first comes in, and say you have a CEAP of 4, then you have a CEAP of 4. It's unlikely that CEAP of 4 is going to go to CEAP of 2 over time. So it's good to capture the status of a patient at a particular point of time. You really can't use it for longitudinal follow-up. So if you had the ability to choose just one metric for assessing venous disease and you didn't have the resources to pursue anything else, sure. CEAP icing is pretty simple. It's easy to administer. And you could just use the clinical component of the CEAP. If you do have the ability to incorporate another quality of life, a quality of life instrument, then my advice would be to pursue that. And the quality of life instrument that you should pursue would depend on the spectrum of venous disease that you see in your practice.
Okay, we have another question too about scoring, specifically CEAP and VCSS. Can you use one CEAP score for both extremities or one VCSS for both extremities, or if symptomatic, should they have a separate score for each side?
Yeah, each limb is considered separately. So it may be that both end up having the same CEAP and same VCSS scores, but you treat each limb as a separate entity. So it might just be C2 in one leg, say a right leg. The left leg might be C4. You may have a VCSS score of, say, for example, 2 on the right side. On the left side, you may have a VCSS score of 6 or so. So each leg is a separate entity. You can't combine the two.
And the IAFC requires that you do CEAP and VCSS. I mean, why can't they just pick one or the other? What's the difference, and what value do each of them bring?
No, that's a great question. So I think CEAP is a static instrument, and it's easy to do, and it allows comparison, and especially when you report your data, it tells us what type of patients, from a clinical standpoint, is being considered in the study. Now, VCSS is able to capture changes over time. And so that's a significant difference from the CEAP classification. So how do you know the endovenous laser ablation that you've done for a particular patient is actually made a clinically relevant change? How do you know that the stent that you put in patient X has resulted in a clinical improvement in that particular patient? The only way you can assess that is by having a score that is able to capture changes over time. And that's what the VCSS does. The CEAP is just, an initial score that is able to capture the status of the patient at that particular point in time. Now, could you not use CEAP and just use VCSS? Well, you could, you certainly could, but there is so much, a lot of the, but CEAP is generally, or the clinical part of CEAP is generally considered like basic, reporting, has got basic reporting status in venous disease. It's just like, vital signs, have temperature and heart rate and so on. It's just like when you're talking about venous disease, you want to be able to tell folks what the clinical class of the patient is. So I think CEAP has got, multiple roles to play. But remember, these are all just clinic metrics, for venous disease. Again, one has to be practical in terms of what one can pursue in terms of quality of life. But if you do have the resources to be able to gather quality of life data on your patients, then my suggestion would be to certainly pursue that.
Great. And it looks like we're down to one last question. The question is, do the questionnaires take into account all the expenses of ulcer/vein care prior to coming to your office for the initial visit?
No. So the quality of life instrument, as well as the quality of life, just gives you a sense of how impacted or not impacted a particular patient is from their venous problem. The clinical metrics tell you what the clinical status of the patient is vis-a-vis the venous problem that they have. None of these measures actually have a cost component for it, or for that you will have to convert your quality of life measures into sort of cost measures. And there are ways to do it. Like I said, it's done more commonly in Europe and in Canada because of the nature of the health systems that they have compared to the US. There are studies in the US that have looked at that, but they're rarer compared to the other countries outside the US.
Okay, we actually do have one last question. I'm sorry. What role does the sonographer have in these questionnaires? Can they give them to the patients? Can they ask the questions?
That's what we do in our practice. They really don't ask the questions. So we use the CIVIQ 20 instrument, and it's just what is practical to your practice in terms of being able to get the patients to answer the quality of life questionnaire, and in terms of getting the data back to your practice without losing that data. So what we found is that, probably the best way to do it is the clinic is usually very busy, right? So people forget things, it's one of many papers that patients have to see and sign and so on and so forth. When they go to the vascular lab, they just go to get a scan. There's not a lot of paperwork there. So when you give them one, this quality of life questionnaire, they're able to fill it out before they get their scan, and the tech is actually able to make sure that they fill it out. If they've not filled out the entire questionnaire, they can actually help them fill it out. Now, it adds some time to the actual vascular lab scan that's there, but you have to spend time somewhere, right? I mean, you have to figure out what is the best way to do it. So far, it seems to be working for us. The patient still has to fill out the questionnaire that the tech does not.
Okay. Okay, with that, we will wrap up. And thanks again, everyone. And a very special thank you to Dr. Jayaraj for his presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Quality of Life Measures in Venous Disease. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.